So one here and one here. Tentative plan. Here second premolar we cannot place. Here one short implant, here one short implant. We don't have much option. The most short implant we have to select and place it because the bone height is very less. How much short we are having? Up to 6 mm implant is there. Next 8 mm is there. So till 6 mm we can place it. Now we will see.
So the compressive implants with the osteointegrate because they don't take supports from the basal wall. One piece compressive implants. They work like crusher implants only.
Yes. See, this is the nasal floor, right? So this is the nasal floor. Okay. If you place a long compressive implant till the nasal floor, you are getting engagement from basal bone also. Even though it is a compression implants, if you select a longer one during surgery, if you go till here, it becomes a basal implant. See the conventional implant now, if you place like this, conventional implant, you are engaging the nasal floor. It is also a basal engagement. So where you are engaging will determine whether it is a basal arc. Okay. So nowadays everybody is engaging the basal bone only. Even in conventional, they are not stopping till here. They are going till the nasal floor. Previously, the conventional implant is available only till how many mm? 16 mm.
16.
From 8 mm, 10 till only 60 mm. But nowadays they are giving at 18, 20, even 22 is there. Even conventional implant. The reason is to go on with this basal bone. Because the basal bone is good in quality, cortical. You can give immediate loading. The failure rate is less. But here, where can we get the basal bone? So that part we will discuss later. The anatomy part.
So by placing this, you don't have to consider with prosthetic or crown, future crown part.
Yes.
You don't have to consider that.
Wherever implant is there, bone is there, place the implant. The abutment should be in a decent position. It should not be too buccal or too leg.
With the prosthetic driven
No.
It's coming to this.
Even if you prosthetically drive a situation, finally implant you will place only where it is available.
Abutment will.
Yes. The abutment it should be in a decent position. It should not be in a very abnormal position. If it is too buccal or too lingual, then it will interfere. Once you give the process, if it is too lingual, speech will.
Doubt is.
Yes.
If it's not a basal implant, you go for conventional.
Okay.
Then also you can do same where.
Yes.
Or you should go for prosthetic driven implant.
When you are placing implant in the bone, make sure it is in a decent position. So that when you fix the abutment, it should be in a decent position.
So the neck is.
See, the abutment can be changed. The abutment position can be changed in a way in conventional. 15 degree, 25 degree abutment is there. In single piece, you can bend the abutment. Okay, in that way you can. But surgically itself, make sure it is in somewhat decent position. After that, you can correct the abutment position by changing 15-25, or if it is a single piece, you can bend it. And after bending also, you can correct some more by abutment preparation, abutment trimming. You can do so.
Both, sir, this basal and compression both can be bent.
Yes. Can be bended.
It can be bent.
Bended. Now we'll see the cross section and we will improvise this planning. First we will see the interforamina planning. So this is a 4-4, right? The mental foramen is coming out. So after extraction, placing implant is not very much ideal here. Why to take risk? Now we will go to the 4. This is the 4. So this is the buccolingual cross section. Buccolingual cross section. So whenever we are reading a CBCT for implant planning, do it systematically. First thing what you have to check is what is the shape or contour. What is the shape? Sometimes it will be like this. Okay, yes. Sometimes it will be like a pear shape. It is almost like a tubular shape. It's almost parallel one. You cannot make any mistake here. If it is like this, then no. If you do the drilling, you may perforate it. But here, once you follow the apex, you will be in the bone. So first, what is the outline? What is the outline of the alveolus or the jaw? Then what is the quality of the bone? Here it is cortical, here it is cortical, here it is cortical, but inside it is somewhat cancellous, but it is quite okay. Here it is good, not very bad. This black or cancellous. So bone quality inside. Then look for any nerves or vessels, important anatomical structure. Any nerve is there. So here after extraction we may do some bone leveling till here. After that we can use this part. So once you do bone leveling here, it becomes a good bone case. Buccolingually there is good bone, height also good bone. You can place a conventional implant also or compressive implant also. There is no need for a basal here. So we'll place the implant here now. This is 4 mm. Sometimes, rarely, if you go deeper, you may touch that loop. Okay. So a mild mesial tilting is no problem. Mild mesial tilt you can do. You will see the 360-degree view. Okay. Can you see the metal foramen here?
Yes.
Metal foramen and its anterior paper coming here. But it is safe now. So what diameter you will choose? So there are many companies, they are coming with a lot of diameter. Am I going to select any 4 range or below 4 range? That is the question here. Either in the 4 range or below 4. 4 mm diameter is available, 4.1 diameter is available, 4.2 based on the companies. 4 mm is Redice, 4.1 is Simpladent, 4.2 is Bioline. Okay. So if you are selecting in a below 4 range, it will be in the 3.5 or 3.75. Okay. So this is a 4 mm diameter it shows. There is some good bonus there. We can select a 3.75 also. Okay. Now we are planning for 4.2. This is the 4.2 area. Now if you see the outline, there is a small C, no?
Yes.
Okay. That is not a problem.
Width is more.
Yeah, width is okay. Width is how much is the width? Even if you do no, it's around 5.2. So if you place a 4 mm diameter implant, only 1 mm will be remaining there. So I will select implant which is less than 4.
Yes. 3.5.
Yes, 3.5. Yes. And length, how will you select? You cannot drill like this. You will be drilling like this and your drill may hit here. Right? Imagine you will be drilling like this. Or if you drill like this, whatever drilling you are drilling, you will be touching the lingual cortical bone. No? See how much cortical it is.
Yes.
So the drill will touch the cortical bone and you will feel in your hand this.
Yes.
It will be, don't try to push it and otherwise you may perforate here.
Yes.
Important blood vessels are there. So whenever you are feeling the resistance, just stop it and measure the length and select the length. That is enough. You don't have to perforate here. Okay. So here we will be selecting a 3.5 No, just check. 3.5 mm will be better. If the ridge is very thin, I may be using a basal implant. Okay, because the shank only will come here.
So normally what we select basal implants?
3.6 diameter you are asking?
Yes.
3.6 universal. All companies they are giving you 3.6. There is no variation in diameter in basal companies. Only when it comes to compression, many companies they produce various diameters.
And so bone width, the call for selecting the basal implants. Like here is 5.2 something.
If it is more thin, even if you use a 5.5, the threads may get exposed buccally. So after 2 months, if the bone resolves, then it is not good. So if you place a basal here,
Okay.
this is only smooth part. It's not important. So the very small diameter compression is 3.5, 3.2 also available, 3 is also available. Okay, you can place 3 also here. So this is 3-2 area. You can see the marrow here nicely.
Yes.
Okay. Here both implants we can place. A compressive also we can place. A basal also we can place. I will tell you what is the advantage of placing a basal here. This width. This width is only 3.6. So if you place a 3.6, the 3.6 it will get engagement from here and it will get engagement from here. Like it is locked in between. So you can use a basal also. So we'll see the second, 3, 4. This is a 3-4, not even 3-5, but this anterior loop is coming. So even if you are placing implant in 3-4, better to tilt slightly mesial. Okay. Okay. And select a shorter one. We usually think that the mental foramen stops at 5, but sometimes it comes anteriorly as a loop or an extension of the canal, incisive canal. That may be the source of some paresthesia or bleeding during surgery, right? So now we'll plan for the distal mandible. The bone is very less here. Just we'll check the second premolar. See, the mental foramen is very close to the crest and also bone loss is there. This is not ideal for implant placement. We are avoiding the second premolar. Just distal to the second premolar. The bone is quite decent here, right? See the outline. First observe the light, then only we will make difference between one patient and another patient. So this is the canal, beautifully seen here. Not always we can see the canal like this. So 2 mm safety distance keep from the canal. You can place a good 8 mm implant. The bone, the crystal bone is good. This bone is good. Okay. We can select a 3.5 into 8. Just distal to the second premolar. And one more implant in the molar. See here. Here this is the canal. Right? This is the marrow spaces. This is the marrow spaces. Here also we can place a. Actually here we can place a longer implant also. 10 also, but 10 becomes very close, but we can do. Here we can select a little bit wider also, 4 mm also. So the left side is over. Right side only there is a lot of confusion. You will see the second premolar. Second premolar is not ideal.
Yes.
Okay.
Yes.
But even here we can place an implant. There is one design in basal called 5.5 design. This threads will be 5.5 loose implanted. So if you place a 5.5, it won't get support from this bone, but it will get support from this bone. This buccal and lingual engagement.
So your calculation starts from where? In terms of length.
Which one? The length.
Okay.
Just by imagination, no, you do alveoloplasty.
No, sir. In the implant, where the stuff.
Yes, from here to here. That I will tell you. Okay. In compression implants, it is different.
Okay.
In basal, it is different.
Because in conventional, we have on shoulder body. From there only we calculate here.
Yes.
This neck and size.
Now we will see the interdental bone between 4 and 5. The 8 mm implant we can place. Right? This is the mesial root of 6. If you see the moment we go into the mesial root of 6, you can see a small projection. That is the myloid ridge. The more distally you go, the more prominent the myloid ridge is. You see? Here the myloid is becoming more prominent. That myloid ridge is important for getting lingual cortical engagement. See, in this interdental area between 7 and 6, here the bone is quite good. So this is 5.5. Previously you saw one base, that is 3.6. This is quite wide. It will get support from the entire socket wall. If the socket wall is very wide like premolar or upper palatal, this is a very beautiful implant to get 360 degree